The procedure for impairing identified physicians in Georgia comes from various sources. When a physician develops an addiction problem, either the family knows about it, or his colleagues, or the hospital medical staff. Unfortunately, currently, it's usually when someone has an event which brings it to the attention. It's not usually one of those "we've been worried about it for a while" kinds of things, but rather a physician shows up early in the morning with alcohol in their breath, or they have, late at night, they come into the emergency room and they seem a little bit confused, and then a drug screen is obtained for cause. Unfortunately, physician health is in a place where we don't do enough preventative screening. We wind up waiting until something difficult happens. And because physicians are often breadwinners in the family, sometimes family is a little bit reluctant to refer to us. Through education, we're moving that forward. What happens with education is that we wind up helping people identify when problems are present. And as an institution, as the Physicians Health Program grows in Georgia, we are getting more and more people referring into treatment before a negative event occurs, which is obviously our goal. Public safety is always our goal. Intervention is done primarily when a physician is identified as having a problem. How intervention occurs is either the hospital medical staff office. There's often, in every major institution, there is a hierarchy. It's a physician wellness committee, it's a medical staff services. Someone sits down with that individual. The Physicians Health Program usually participates, either over the phone, or if it's close by, we actually will drive out and sit down with that physician. Our goal is to help physicians who have a substance abuse disorder know that help is present, and if they take care of themselves, they get the help they need, they can return to happy, productive lives. But if they don't, then they risk really severe consequences, including sanctions to their license. So we have kind of a good news story, but also a little bit of a hammer that's involved in intervening. Physicians that develop addiction disorders have very complicated continuing care. The model is best seen as through the eyes of a paradigm called contingency contracting. If once initial treatment has been completed, which is any time between 6 weeks and really 3 months, sometimes even longer, physicians have enough skills they have enough drug refusal skills, they have enough living skills, they have enough, their support network is built up sufficiently, so that we think if we provide a framework for an outcome should a relapse occur, we can increase their long-term prognosis. So, outcome. What we do after the first phase of sending this individual off to treatment, we don't do the treatment ourselves. We're really the intervention, as you say, identification, sending them off to a treatment provider that we think matches that physician's needs, so we do help select the treatment. They go off to a treatment center, they come back, and they sign actually a contract with us. The contract is what we call a containment contract. It really says, these are the things you have to do to continue to practice medicine, to continue your life, to continue your license. In that contract are random urine drug screens, 2 years of group therapy. We believe that group therapy is helpful. In addition to that, there's 2 to 5 years of attendance at support group meetings, which are of twofold. The first is what falls under the moniker of caduceus groups, and caduceus groups are really large groups of physicians with anywhere from 30 days of recovery to 10 years of recovery. And in that group, they say, oh, this is what I should look like or be like in 10 years, even though I'm not there yet. And then with the random urine drug screen, small group therapy, caduceus groups, and then some of them need individual therapy. Some of our folks are sent to relapse prevention training groups if they need shoring up in that area. Each person is different, but the three biggest components are the drug screens, the small group therapy, and the caduceus groups. Everyone does those. And then part of their contract, the last part of their contract, is the involvement in support group meetings, 12-step support group meetings, which they are required to do. And we believe that the documentation is important. They have to supply us with the names of the meetings they're going to, who they talk to, that sort of thing. And that kind of holds them accountable during that period of time. I came from a family of healthcare providers, and there was an individual in my family, not my immediate family, who was a physician who actually got in trouble with their addiction. And part of growing up in a family that was surrounded with medicine is I got to see the goods and the bads of physicians. The goods are they give their lives to other people. The bads are they often suffer as a result. They don't tend to take care of themselves. And I too had difficulties with figuring out how to care for myself. All that together is, once I figured this out a little bit, I said, I'm going to figure out if there's a better way of doing this. I'm going to figure out if there's something that we can do to help physicians learn how to care for themselves at least as well as they care for their patients, which is kind of makes sense, but it's apparently not intuitively obvious to the physicians I treat. So all that combination, I started working in hospitals when I was age 16 as an orderly, and I continued that throughout my life. Hospitals were kind of part of my growing up, if you will. So that experience led me to wonder how this could be done differently.